Hi, my name is Erin Sowers, and I'll be presenting to you a presentation on the ethical dilemma of do not resuscitate orders versus cardiopulmonary resuscitation, commonly referred to as DNR versus CPR. My question to you is, what is more important, quality of life or quantity of life? Should healthcare workers be more proactive about talking to their patients about their code status? And if so, how should code statuses be addressed? Should healthcare workers even encourage DNR orders for certain patients, such as those with multiple medical issues, the elderly, the frail, or the terminally ill? I chose to talk on this topic because many patients and their families fail to realize or lack the understanding of the actual survival rate and the effects of CPR. Also, many do not consider their options unless it is brought up or it's too late. Some people believe or want to believe that they will live on forever. They fail to realize that death, like birth, is only a natural process of life. Now, I believe that all people have a right to make their own healthcare decisions, and I respect that with all my might. But I also believe that we as nurses and as part of the healthcare team have a duty and should be sure that our patients are fully informed on their options and know their risk and benefits of their decisions. My first personal experience of dealing with this ethical dilemma of DNR versus CPR took place when I was only 5 years old. My grandpa of 72 years had a heart attack. And I remember as he laid in the living room floor, my mother and my cousin Sheila, who both had previous experience in healthcare, done CPR until the ambulance arrived. And at that time, the emergency medical technicians took over. My grandpa was revived, and when he was able to talk again, he said, "What in the world were y'all thinking? I was on my way to heaven." He lived 5 years after his heart attack, in which quality of life was diminished thereafter. He suffered with poor memory and slow word recovery. He passed in 2001 with Alzheimer's disease. CPR, cardiopulmonary resuscitation, was developed in the 1960s to revive victims of sudden death, of death that was only accidental, deaths such as drowning, those with electrical shock, or a heart attack in an otherwise healthy person. CPR was not developed to revive people with multiple medical issues or the terminally ill. However, in this day and time, it is a standard that everyone is a full code, meaning that all resuscitation measures will take place unless otherwise noted with a DNR order. This standard is only reasonable because delay in treatment for someone needing CPR would decrease the chance of survival. Now, it is important to realize that during CPR, a great amount of force is applied to the chest during compressions. This force often results in a broken rib that could also puncture a lung, leading to respiratory difficulty, or puncture a spleen, leading to hemorrhage. It is also important to realize that during the time that the patient's heart and the lungs are not functioning, the brain was going without oxygen. And the longer that the brain is going without oxygen, it leads to brain damage, causing confusion or difficulty with thinking and inability to properly act the way they did prior to CPR. The 24-hour survival rate of CPR is only 9.2%. All too often, when one does survive CPR, it leaves the life in a devastated state. A do not resuscitate order, DNRs, was developed in the 1970s as a method to give competent patients the chance to determine under what circumstances they still choose life. DNR orders fall under the common law in which patients have the right to refuse healthcare treatment. In 1991, Congress developed and passed the Self-Determination Act, stating that all people have the right to make decisions regarding his or her health care. They have the right to accept and refuse, and also the right to make advance directives. Therefore, the question rests with the patient. What does the patient deem important? Would the patient rather have quantity or quality of life? CPR often extends the patient's life at the expense of quality of life and delays the expected process of death merely by maintaining heart and lung functions. Because everyone entering the hospital is considered a full code unless otherwise noted, CPR is often instituted as a result of lack of decision making rather than a part of a considered plan. CPR entails dramatic effects that many may not wish to endure. Therefore, it is important for us as the medical personnel to review code status early in the hospital encounter. The pros and the cons of DNR status. The pros. The pros of DNR is that it lets death occur naturally. It promotes quality of life, it preserves dignity, and allows for early implementation of palliative care as needed. The cons. The disadvantages of DNR status. Families misinterpret DNR orders as giving permission to terminate a patient's or a loved one's life. It also makes them feel as if they are given up. My current stand on this ethical issue is that I value quality of life versus quantity. I personally believe that DNR orders is beneficial for anyone who is elderly, frail, has multiple medical issues, or is terminally ill. DNR orders promotes quality of life and allows for a natural death to occur. As stated before, I respect my patients' decisions, whether they be for or against DNR orders. However, I believe that the patient and their family should be fully informed on their decisions. In the nursing practice, the issue of CPR versus DNR, quality of life versus quantity of life, arises daily. Even as a new nurse working on the medical floor, I've had patients that are 90 years old that have full code. Also, I've had patients that are completely dependent that are also full code. It is clear that either of these two patients or anybody else who is elderly, frail, has multiple medical issues, or is terminally ill, if they were to go through with CPR and survive, their quality of life would be greatly diminished. Oftentimes, patients remain a full code because a conversation of their options has never been properly addressed. Many ask, do you have advance directives such as a DNR order? If the patient answers no, then the healthcare worker simply just moves on to the next question. However, we should do more than that. If the patient answers no, we should say, oh, would you like more information about that? Taking proper measures to address the patient's wishes for end-of-life care promotes patient dignity and puts ethical principles such as fidelity and autonomy into action. In the making of this video, I used 6 nursing journals and in addition to my life experience and educational experience.